All right, good afternoon, and thank you for joining us today for the second part of the COVID-19 Town Hall for CHWs, Where Are We with Variants and Where Are We Headed? My name is Dina Pimenova. I'm the Senior Project Coordinator for the NYU Langone Community Health Worker Research and Resource Center, housed in the Department of Population Health at the NYU School of Medicine and supported by the NYU Langone Community Service Plan. Today's event is co-sponsored by NYU Community Engagement Alliance Initiative, NYU CUNY Prevention Research Center, and the NYU H&H Clinical and Translational Science Institute. Next slide, please. Before I introduce our speaker, I would like to review some housekeeping. Everyone is on mute. You can enable or disable closed captioning by selecting live transcript at the bottom of the screen. The chat box is open for comments and sharing of resources. If you are trying to reach all attendees, please select everyone, not just hosts and panelists. We ask that you please use the Q&A box to submit questions to the speaker. We will have time to answer as many questions as possible during the Q&A portion. The slides and the recording will be made available. I will email those out as soon as possible. And please be sure to fill out the poll at the end. Next slide. Great. So we will first have a presentation that is geared primarily towards community health workers and frontline staff working directly with community members about existing and emerging COVID-19 variants in the city and projections for the pandemic. This will be followed by a Q&A. Today, we are excited to welcome back Dr. Anna Bershteyn, who is an assistant professor of population health at NYU Grossman School of Medicine. She advises the New York City Department of Health and Mental Hygiene on COVID-19 forecasting. She was previously a senior research manager at the Institute for Disease Modeling of the Bill and Melinda Gates Foundation, where she developed mathematical models for global disease control and eradication. Our Q&A moderator today is Andy Yu. Andy is a program counselor working for Family Support Services at NYU Langone in Sunset Park. In this role, Andy screens community members for various needs, helping with applications for benefits and referring to community agencies for needed services. Additionally, Andy conducts community outreach for COVID-19 related services, such as scheduling clients for vaccine appointments and participating in community vaccine events. Previously, as an AmeriCorps member, he worked at NYU's The Table Food Pantry, where he found his passion for community service. He also holds a bachelor's degree in business management. And with that, Dr. Bershteyn, the floor is yours.
Thank you so much, and it's wonderful to see so many of you here. Thank you for joining. So today I'm going to tell you a little bit about some of the trends and data in the COVID-19 pandemic right now and what's driving those trends. So we'll talk about variants and what we know about them. Then I'll share with you actually some of the recent forecasts that my group has made and shared with the city health department. And you'll see that the variants are very important in deciding what happens next. And then last, we can discuss what we can do about it with so many different COVID variants coming our way. Next slide, please. What I'm showing here first is an overview for the entire United States. I know there may be some people joining from other states besides New York. This is the weekly number of COVID-19 cases. And here you can see historically, and then just a short-term forecast from an ensemble of models that the US government uses. So you can see that actually cases are relatively low right now, but we have to be mindful that there is a great deal of underdiagnosis because of the availability of home tests, which are generally not reported to health authorities. And the next slide here just shows the hospitalizations, which also you can see right now are relatively low as COVID waves go. So we can look back at the large number of hospitalizations that occurred in the fall and winter of 2021 before vaccination was widely available, and then a shorter but also very tall peak in January 2022 due to the Omicron BA.1 variant. So you can see we're not in a tall peak right now. There's sort of a broad hump of hospitalizations, which is slowly creeping up. And this hump, as we're about to see, is due to multiple new variants that have spun out of the Omicron lineage. Next slide, please. And then lastly, here are deaths, weekly deaths in the United States, again, historical and forecast. And this is a very good news story. You can see, compared to deadly waves that have happened in the past, that reported deaths are currently low and relatively steady. So this is reflecting the advances in vaccination coverage, which even when not effective against breakthrough infections, can reduce the risk of hospitalization and greatly reduce the risk of death, as well as new treatment options like Paxlovid, the antiviral that people can receive relatively easily, as well as other treatment options for people who can't receive Paxlovid. And then at the end, we'll talk about for people who nevertheless progress to requiring hospitalization, there are also treatment options available which are reducing mortality rates. Next slide. So looking at a curve like this, you'll see that there are these spikes that happen over history. And what we've seen with COVID-19 is that each wave or spike in cases, hospitalizations, and deaths seems to be attributable to usually one, sometimes a couple of simultaneous variants. And so we have our original variant that swept through the United States. Unfortunately, a lot of that mortality happened here in New York. Then the Alpha variant, which caused this spike in the winter of 2020 through 2021. Then we had the Delta variant, which came later that summer. And then the Omicron BA.1 variant over the holiday time of 2022. You can see that now mortality is relatively low, but if we zoom in, this is for the entire United States, but if we zoom into one location where we're really focusing in one place where the waves are very synchronous, we can resolve even more information about the variants. So let's go to our next slide. So this is just New York City cases, not the entire United States. So you can see the waves are a lot more contained because the United States is a big place. So a variant might peak on the East Coast and then later on the West Coast, and it all gets sort of smeared together. But when we look at just New York City, we can see very clearly the original Alpha, Delta, and then this very tall peak, the Omicron BA.1 wave. But we can also see more happening after that. We can actually see waves from variants that have spun out from Omicron BA.1. So you can see there was a peak from Omicron BA.2. And then right on the heels of that, that variant came another variant called BA.2.12.1. It's a mouthful, and I see I accidentally dropped a period. It should be BA.2.12.1, so tough one to remember. And then the last one, the one that we're experiencing right now, is a mix of two variants, BA.4 and BA.5. So you can see really the picture has changed since the Omicron group of variants have come about. Before, we would have one wave caused by one variant, and then we got a break. We had a period of quiet. So that summer 2020 was a beautiful time, and early summer 2021 before Delta, where people could just catch their breath, not worry about COVID so much because transmission was very low. Percent positivity of testing was under 1%, sometimes a small fraction of 1%. But since Omicron came about, there's this new phenomenon that really caught scientists by surprise, which is the variants are coming at us so fast that one wave hasn't even finished before the next wave comes right on top. And so you can see each of these bumps, they're caused by different variants, but there's been no break in between. It's just been one after another. And the current wave that we're in is really different in that it's a mix of two variants, BA.4 and 5. So let's go ahead and look at the same data for New York City together. Next slide. So here's hospitalizations. And you can see a good thing is that hospitalizations are becoming smaller due to vaccination and all the things we discussed a moment ago. And then the last one here is deaths. One more slide, please. And you can see a similar thing that the later period of time, the deaths are also coming down. And actually the deaths are so low, we can't even see the bumps from each of the 3 most recent variants. It just sort of looks like a wiggle at the end of this curve. Next slide. So let's understand these variants that are behaving very differently than they did in the first couple of years of the epidemic. As I mentioned, the currently dominant variant is BA4/BA5. These are 2 sub-lineages of Omicron, which seem to go together, and BA5 is the more common of the 2. And you can see this is the green here at the bottom. The darker green is BA5, the lighter green is BA4. You can see these variants rising over time, and they're pushing out in red BA2.12.1, and then before it BA2, and then that purple is BA1, the one that caused that huge surge in January, which just has gotten completely squeezed out. Next slide. So what do we know about BA4/5? Why is it spreading? Why is it coming right on top of the one prior? Well, one thing that we think we know is that the R number, the R naught for BA4/5 is approximately the same as the variant that came before it, the mouthful BA2.12.1. And what that means, R naught, is that if there were a population that had never been vaccinated, had never gotten COVID-19, imagine an isolated island, and someone showed up with COVID-19, how many people would that one person infect? So it's basically a measure of how intrinsically infectious something is. Does it spew out of the nose and mouth in huge amounts and drift all over the place? Or does someone have to really be close in and have very close contact in order for transmission to happen? So it's about as transmissible in the sense of R naught. But BA4/5 is evading vaccine protection against becoming infected. It's about 1.7 to 2.3 fold greater, has greater vaccine evasiveness compared to BA2.12.1. Now, the good thing is the vaccines will still reduce the risk of hospitalization and death very well. They just don't protect people from having an infection, which they will probably experience at home without ever needing hospitalization. The severity of BA4/5 is likely similar to the earlier Omicron variants, although the evidence is mixed. So on the one hand, laboratory experiments are finding that this variant has a greater predilection for infecting cells in the lower airway. So there's a concern, instead of just staying up in the nose and the upper respiratory area, that it may replicate deep in the lungs where it can cause more health problems. But on the other hand, the country South Africa already had a wave of BA4/5, and there was no difference in hospitalization or case fatality rates compared to BA1, the first Omicron variant. The estimated ratio is exactly 1:1. So far, and so far here in New York City, we're not seeing a difference in severity based on the counts of hospitalization and death. So let's keep our fingers crossed that the severity of this variant, even though in the lab it showed this sign of infecting lung cells, will not manifest in populations. Next slide, please. And then how common are reinfections with BA4/5? Well, it turns out reinfections are more common, and the percent of infections overall that we see that are reinfections is about 25%. So that may surprise some of you. You may feel like everyone who's getting it is a reinfection, but it's only about a quarter of infections, and 3/4 are people who are getting COVID for the first time. And this is still higher than before. So before Omicron, only 1% of people who were infected were having a reinfection. During the BA1 wave, that sprang to 10%. So it is increasing. The graph on the right, it's a little bit of a confusing graph, but what it's showing is in England, where they actually track who's getting their first infection versus a reinfection, which we don't keep as much track of in the United States. It's showing what percent of infections are reinfections by age. And you can see the young are on top, age 10 to 14, and the old, age 60 plus, are on the bottom. So who's likely to get reinfected? People who are unvaccinated, people who are younger, and then people who had no symptoms and low viral shedding on their previous infection. So they actually didn't get as much immunity the first time, and now they're becoming reinfected. Next slide, please. The good news is that reinfections are often less risky than initial infections. So here you can see symptoms and viral shedding, this graph with all those lines, on the top for an initial infection and on the bottom for a reinfection. So you can see that more of the dots are yellow, meaning more people don't have symptoms on reinfection, and all the lines are going to the left, meaning they're producing less virus from their nose on their reinfection. But every person's experience is different. So you will hear stories of people saying, I had a much harder time the second time around. Those people are just more rare. There's a study that's been in the news from the VA that seemed to show that reinfection led to worse outcomes. And there's just a picture here to explain why that study is really misunderstood. What the study showed was if you have people who had a first infection, and there on the left, that first hump on the left is the risk to their health. And then some people had a reinfection in pink, and some people didn't in the darker blue. It's worse to have the reinfection than not to have it. So this study reported how much higher is the pink than the blue. Sure, it's worse to get the reinfection compared to not get a reinfection, but that doesn't mean that the pink curve is taller than that first blue curve. Actually, it's less risky. There's less risk to a person during the reinfection compared to their earlier infection. So I just wanted to point that out because that study has been all over the news and it's confused people, but do rest assured that on average, reinfections are less risky. Next slide, please. So what does this mean for summer 2022? I'm going to show you a similar curve to before, but with my lab's forecasts. So here, this is just New York City. You can see the data on daily cases in gray. And then here's how tall the peak might be for BA4 or 5, depending on if it's 1.7 times more vaccine evasive in blue or 2.3 times in green. So you can see we are in for a hump that will be greater than the two mixed together humps we just had, BA2 and BA2.12.1. But as you can see on the left for comparison with BA1, we had 60,000 cases a day at the peak. And even in the worst case, we think we'll stay below 10,000 a day with the peak that's coming up. Next slide. Here's the same thing, but just showing you percent positivity. So it looks like the data might have been following the blue line, but actually when you look at percent positivity in orange, we might be following the green line after all. So we're still uncertain about that. Next slide. This is just to show the hospitalization data. And you can see that hospitalizations are again going to increase, and we'll have a bump that's higher than it's been since these two April through June peaks, but not as high as the Omicron BA1 peak. And you can see that technically that red line across the graph is the threshold for high transmission. So we're going to go from medium back to quote unquote high transmission, although the city is no longer recommending that people, that they're no longer enforcing those transmission levels here in New York City. Next slide. And then finally, deaths. I think this is the best news of all, that the deaths are expected to stay below 25 a day, which, that's still, these are deaths we want to avoid. We want at-risk people to vaccinate and mask. But compared to, say, the Omicron BA1 wave of 145, or that initial original wave of more than 800 deaths a day, it's not going to be that scary this time around. Next slide. And I'll just point out that variants are going to keep coming. We haven't seen the last of them. And in fact, we already know of a variant that's being called BA275, sometimes called Centaurus, which is already spreading in India. And you can read about it in the news. We don't know too much about it yet, but it seems to be a candidate for what the next wave will contain. Next slide. So I showed this slide in our last meeting, so I'll just skip over it or skim it this time. But it is important to think globally. If we ever want to get off this treadmill of variant after variant after variant, we need to not just focus on our city or our country, but really help the world, and especially the places that lack access to vaccines, tests, PPE. People, especially who are immunosuppressed or have frequent contact with animals, which are two places that variants could come from. And we need to make sure that health systems everywhere have the ability to sequence variants, to monitor, to provide PPE to health workers, and to be prepared in the event that we get a very bad variant, to be able to protect their population without all of the horrible side effects of the lockdowns that we've seen so far. Next slide. So I just wanted to briefly remind everyone of vaccination guidelines currently. First of all, you'll notice if you go to the CDC website, now the terminology is being quote unquote up to date on vaccinations. So you're not really fully vaccinated, or their term is up to date on vaccinations, unless you immediately get all vaccinations recommended for you. And that includes boosters. So we're going to see a change where it's not enough just to have those first 2 doses. What we used to call fully vaccinated, we're going to expect people to be quote unquote up to date. And what that looks like is finishing a primary series, which is 2 doses of Pfizer or Moderna vaccine. Here I'm showing Pfizer, and then 1 booster, or if you are age 50 or older, or and at least 4 months after your first booster, or you have a high-risk health condition, you need that second booster as well. So a total of 4 doses. Next slide is probably just the same thing for Moderna, very similar, where you need 5 months after the primary series of 2 doses, you need 1 booster. In another 4 months, if you're over 50 or high risk, you need another booster. Next slide. And then J&J. I know there's not quite so many people receiving J&J nowadays, but for people who have received the initial 1 dose, they need a booster at least 2 months after that 1 dose, and then a second booster, again, for the 50 and older. Next slide. And I'll also just say, optimistically, we saw those low deaths, and in part we can credit treatment options. So next slide, I won't go through this in great depth, but there are now options all along the way, from the moment someone tests positive all the way to when they're hospitalized, when they're discharged from the hospital or discharged from the ED. And you can see there are 4 different options in that top box for people who have just tested positive. In order of preference here, the #1 option is Paxlovid. And so I'm putting here a phone number for New York City. There's a city resource here. There's a state resource. There's a federal resource. There are a lot of resources out there to help people get Paxlovid, and it doesn't even require an in-person test. Some providers will prefer either a proctored online test or an in-person test, but the guidelines say even a patient's own attestation. So if you took a home test and you are willing to vouch that you tested positive, that could be enough to receive Paxlovid. And then remdesivir, which is injected, is a second option. Bebtelovimab, which is a monoclonal antibody, as a third option, and molnupiravir, which is a drug, as the 4th option for people. So this is in order for, in case there are people who can't take Paxlovid because they have interacting medications that they cannot pause. Next slide. And I'll just close with thinking about our population level response. So I think this should be my last slide here, which is the last time I posed this question to everyone here: how should we respond to COVID-19 as a society? And really suggested that people think about these waves that come and go, with bad times and then good quiet times, as, you know, no matter what is happening with COVID, we want our vaccinations up to date. We always want to be promoting hand hygiene and staying home when sick. That's just healthy behavior. We want to have clean air exchanges when we're indoors. That's, again, great for general health and something we want to establish, you know, when it's not in crisis mode. And we may want testing for certain people, certain priority populations, like long-term care facility staff. You know, there are things that we want in the height of a wave, but that we don't need all the time. Things like mask requirements, proof of vaccination, capacity limits, testing for everyone in the population. These are things that are disruptive to day-to-day life. They're costly. People don't like them. So we'll do them when transmission's high, but we can relax when transmission is low. And then we really want to avoid closing schools, businesses, travel bans, postponing elective and preventative care as much as possible. So that's something that we would only consider if there were an extremely severe and deadly variant that came about. So, you know, before I was really envisioning this world where we will move between the always and the sometimes, the same way when the weather gets cold, you put on a coat, when the weather's nice, you take off a coat. But, you know, these past few weeks have been confusing. And I think many people now are on a continuum between the always and the sometimes, because we're not getting any breaks between the variants. People have to learn to live their lives knowing that transmission is not low, that it's out there, and we don't know when we will get a break again. And so it really is a continuum where people have to think for themselves, how much do I want to avoid COVID? How much do I want to go back and live my life? What's the right balance for me? Doing everything in the always box, but picking and choosing things from the sometimes box, depending on the circumstances. So, for me, for example, I spend time with very elderly people, so I do mask indoors very consistently. But understandably, there may be circumstances where some people may not want to mask if they're in a safer situation, or if they personally feel that they're at low risk. So it's a tricky time that we're in. Next slide. So that's what I have for you today, and I'm so excited to take your questions. And I'll pass it over to Andy to moderate.
Hi, thank you so much. So for our first question, it will be as in the beginning we talk about like the at-home test kit, where we talk about how it's on just because we're right now doing at-home test kit, so it's very we're unable to like detect it. So my first question would be like with the current COVID testing option, can you discuss a little bit about the role between the community versus at-home test kit to protect individual and public health? Like, how does it impact our society now?
Yeah, that's a great question. So currently the testing options, there are really 4 options for people. The first is a PCR test. So those were the first tests that came out. They will take a day or more, sometimes 2 or 3 days to return results. And you can get them from a healthcare provider or from a testing site. So the city has mobile vans and brick and mortar sites throughout the city. The second option is actually those same providers and those same sites provide rapid antigen testing. And so you would go to one of those sites, you would get swabbed, and amazingly, within 15 minutes of walking away, you'll receive a message on your phone telling you your result. A third option is a proctored test at home, where you buy a special test kit and a provider will watch you swab yourself and stick it in the test and do the instructions, and then you'll see your test result, and so will the provider. And then the last option is just a regular at-home rapid test kit, which you can pick up from public libraries throughout New York City. Schools send them home with children, or you can purchase them at a pharmacy. And so, all of those are great options. The PCR is slow. So, if you want to get an answer right away, it may not be the best test for you. It is more sensitive, however, and in some situations, people need it. So, for example, my child's summer camp asked us to go and get a PCR test in the 3 days prior, because even if it was a low-level infection, they didn't want my child, who was going to be in such close contact, spreading it around. The rapid test is, at home is really great. You get results right away and you don't have to coordinate or go anywhere. And then either the in-person antigen test or the proctored antigen test is a good option if you need to show that you're negative. So for example, if you need to attend an event that requires a negative test beforehand, or